Hello, I'm Stephen Rich from the University of Maryland, and I have the pleasure today to interviewing Dr. Stephen Frucht for the MDS Oral History Archive. We're coming from Copenhagen, and those who were chosen to be part of the archives have made significant contributions to our field as well as to the society, and Dr. Frucht certainly is deserving on both of those qualifications. So, Steve, thank you for agreeing to the interview.
Well, thank you for inviting me. I'm humbled and honored.
Good.
Thank you.
Well, let's just start at the beginning a little bit. Can you tell us a little bit about your upbringing and your early education?
Sure. Well, I grew up right in New York City in lower Manhattan in the Lower East Side, went to public school, went to college in Boston at Harvard, and then stayed there for med school in a combined program through Harvard and MIT, which was called the HST program. And, originally I think, like many kids, I was interested in science. I had a strong interest in music as well and went to the Juilliard pre-college program and continued to do music throughout college. And then after med school in Boston, I came back to New York. And so I've been in New York now for 30 years for training at various places on the island of Manhattan.
Tell me a little bit about your parents, what they did, and
Sure.
how they might have influenced you either scientifically, medically, or musically.
Sure. Well, it's interesting, particularly with what's going on in the world, because I looked this up. My father's father came alone on a boat from Galicia, which is in western Ukraine, at the age of 11, if you can imagine such a thing.
Right.
This is what all four of my grandparents came through Ellis Island, but he came there. You had to have a sponsor, so you can look on the Ellis Island registry where they wrote down the name of every single person and where the address they were going. And so he came. The story I was told was that there were musicians in the family. They were all lost in the war. And then my parents were both born in the United States in Brooklyn. And they both were New York City public school teachers, both in math. Though my mom almost finished a PhD in economics, and my father actually got a master's degree at the Courant Institute later in mathematics, so he had a lot of wide-ranging interests. But I think I probably fit the stereotype of, back then it was first generation became teachers, and then the second generation, hopefully, we're going to do something in math, science, engineering, law, whatever. So it was, it is certain, sometimes I think back and I think, 120 years ago, how did I end up here when
Right.
somebody, just made a prescient decision that things were really going south in western Ukraine and stepped on a boat and that was it. And growing up in New York City in the 70s was a little bit interesting time. The crime rate was much higher then, but as now, New York City had so many opportunities. I mean, musically, it was like incredible. And certainly through Juilliard pre-college and meeting people who also had a very strong interest in music and establishing connections to them was very meaningful.
Were your parents musicians?
They were not. I think my dad, though, had a lot of natural ability because he could harmonize and did. He taught himself to play the piano. He taught himself to play the violin. So I think there was, but back then there wasn't a lot of money.
Right.
It's not like people gave scholarships for study or this or that, which
Right.
I was fortunate to get growing up, but it was a very different era. If you lived in the city and you were interested in science, you went to CUNY.
Right.
And that's why CUNY had a list of people later who were involved, of Nobel laureates and all these people who did amazing things in the city. But it was a very different time.
We're going to come back because I know music has been a part of your sort of your life, and both professionally and personally in your family life, and I want to come back to that. But you finished medical school, and then what was it that interested you in neurology?
Right. Well, you know, when I was going through medical school, I first thought I would do hematology because I had spent time as a college student. I had done a lot of work in labs, and then I spent about 6 months every 1 week one morning per week at the Dana-Farber Jimmy Fund, seeing amazing things. And I certainly liked the visual aspects of looking at slides and hematology and all, and then thought, oh, I'll do that, but then went to med school not quite knowing what to do. But in the neuroscience course, I think the thing, maybe two things that sort of attracted me. The first was that I just found it fascinating that you could listen to somebody and then localize the problem with some probability just by what you knew, which seemed kind of wild to me. And then the second thing, if I have to be honest, is that the people I was in med school with, about a third of them with PhDs, and many of them were going into science labs, and it just became clear to me that that was probably not the best thing for me to do. But I recall being at the back of the lecture room in the sort of the second year, and back then they had slides that would go in, and someone had to stand there because one would go off and it would jam, okay. And they were going through cases in neurology. And so I saw the whole room, and so they put up, you know, a case. Here is a young person and has developed myoclonus and this and that, and they put up a picture of the retina. And so I said, oh, I know what this is. And I just waited, and nobody answered the question. So I said, oh, well, I think that's Tay-Sachs or sialidosis or something. He said, yes, okay. And then they did another one like that, and again, I just waited. And nobody answered the question. And these are people, I mean, I've never been in a room with so many high-powered people. And I thought, maybe this is what I could do. This might be something that I could take advantage of. And then I worked for a year for Eddie Koo and Dennis Selko's lab. That was right in the period where soluble beta amyloid was discovered, and the genetics, and it was really fascinating. And I enjoyed that year very much. I think I also learned that probably running a basic science lab was not for me. I just didn't have the wherewithal or the personality or the resilience to sort of overcome so many hurdles that you have to do for success in science. And I ended up coming back to New York, actually, because then my dad got very sick, and I had to come back for family reasons. And it turned out to be, you know, fortunately or unfortunately for the circumstances, a good thing, because probably my interests were more allied to what I would call New York neurology than Boston neurology. They're very different in my opinion. And how, I mean, like Boston neurology was, at least from a medical student's perspective, was a little more ivory tower clinically. And New York neurology was much grittier, and the volume was enormous, the distribution was enormous, and there seemed to be the same number of neurologists in New York as in Boston, even though there were 20 times the people. So, so I ended up going to Cornell and to train right at the end of his tenure with Fred Plum and Jerry Poster, and those were two seminal figures for sure for me. Absolutely. And you know, it was a remarkable thing seeing both of them up close, and I was able to be a chief resident with Dr. Plum before he stepped down, and then with Dr. Posner, who was still attending on the wards and all, and there's a reason that they had the impact that they did, just the way they thought and the dedication to individual patient care and attention to detail was just incredible to witness up close and watch it happen. And those had a big impact. And then, you know, what about movement disorders? I think, honestly, I had some exposure because as a second-year medical student, after having spent one of the summers that I did at Tanglewood as a fellow in violin, course, I met Leon Fleischer there and actually got to work with him
Right.
one summer.
And I think Bernstein too. I
Yes.
saw on your
Yeah,
on your CV.
he is one of my heroes, and I got to play in 3 concerts with him, and actually to be concertmaster of his second to last concert in 1990, as he was dying, but had hidden this from everyone. And but I had met Leon, and I had some exposure to what dystonia was, which wasn't
Right.
on everybody's, radar back then.
Right.
And I cold called Fred Hochberg at the Mass
Right.
General Clinic, and he very graciously let me shadow his musicians clinic on Tuesday evenings for about a year. And so I first saw patients with dystonia there. And so that, I guess, idea was planted, and then when I went to train at Cornell, though I still hadn't had a lot of movement disorder exposure, because back then anybody who was interested in movement disorders, well, you went and spent a month with Stan up
Right.
at Columbia. That's just what you did. That's where all the patients were.
Right.
And when I did that in January of 2016, of 1996, excuse me, of course I was on Stan's coattails for about a month, going from room to room, and met Paul Green and Blair Ford and Susan Bressman, and was a little bit like, okay, that's it. I'm not interested in anything else. That's just it. And sorry to say that I think I learned what I needed to know about stroke and ICU and epilepsy and all. But from that point, when I came back, I asked them to buy me a video camera, and I was videotaping patients, and I was reading about movement disorders and starting to get involved in the field. And that, when I mentioned this once to the late Blair Ford, who was a dear friend and an amazing clinician and all, his response was, it's a little bit like Harry Potter, the wand picks the wizard. And I think that's true about residents who sort of find movement disorders as a clinical field. It's usually they're just taken with it.
Right.
And they're taken with the history and the exam, and now with therapeutics and everything. But back then even, there were therapeutics, but not like today.
Yeah.
So.
And Stan was obviously a very important mentor for you.
Oh, yeah.
And can you tell us a little bit about what he was like as a mentor, and maybe thinking about how that has influenced you? And because you've mentored quite a few.
Yeah, I have
people
thought about it
yourself.
very much. All the lessons I learned. The first lesson I learned was you go to, do that because everybody spent a month. So you would write a letter, and then you get a letter back saying, yes, you can come here this month. Just
Right.
one sentence. So I thought, that's brevity. Okay,
Right.
that there's something to learn. The second lesson, I showed up the first Tuesday morning, 6:45, which was video rounds from 7 to 9. And the door was locked because I didn't have an ID out there. And Stan came up, and so he put down his stuff and he said, I'm Stan Fun. And my first reaction when he said that was, how can that be? Like, why are you carrying 24 bagels? And and it turns out that he was bringing the breakfast.
Right.
So he brought the breakfast for everybody on that day, and they rotated it. But that was the second lesson I learned, that the boss brings the bagels.
Right. Right.
And
Where
then
he was not above that.
no,
Right. That he was. Yes.
and so then I saw what video rounds were, and then if you just were going from room to room, you realized the clinical approach and many things that either consciously or subconsciously I just copied, which was, an approach where there was never not enough time to deal and address patients and their families' concerns.
Right.
And he was legendary for going later and later and later as the day got longer,
Yeah.
running several rooms, but it didn't matter.
Yeah.
It didn't matter if we were 3 hours behind. I never saw him rush once, working 2 days a week with him for 2 years. And then, I was fortunate to join the faculty there, and many things that he set in place sort of I copied. I was the myoclonus research fellow, and then watching how he, organized people around him to make contributions, to focus, as he put in the little thing for the fellowship, and we work on patients' problems. It was a novel idea. Like, we actually work on them. Okay, the patient, we don't have therapies for Michael. Okay, we're going to create and validate a rating scale, and we're going to do clinical trials. And we have a foundation. So then I thought, well, how are we going to serve musicians with dystonia? We need to have a foundation, which we created with my friend Glenn Estrin, and then became part of the Dystonia Medical Research Foundation, and then that all of a sudden brought in patients who everyone thought, well, where are they? Well, if you have something to offer, I learned, then they suddenly start coming out of the woodwork. Why would they come in if you have nothing to offer them? Like, what do you say? You know, dystonia is rare. You know, you'll never find the patient. Well, if you don't have anything to offer them, why would they come in? And then, of course, the things that are important of seeing how you sort of give one talk, and then if you really invest in it and do it, and then the next and the next. And the other thing, just watching, was how hard he worked, which was remarkable. I mean, you know, he would finish whatever at 7 o'clock, having gone room to room to room, and then begin, I guess, what was his real work of organizing and answering emails and the research and the other projects. And, you know, how do you accomplish so much? It's just, a part of it is sheer determination and working systematically this way. And, you know, I think it's an approach to patients as well that I've probably subconsciously emulated. You know, even such very basic things as what you do when you enter the room. How do you address people? How do you sit down and face them? Where are you in the room? What are you thinking about? How are you reading the room? And then just the idea of, well, they're going to then give you feedback after the visit, sometimes many times before the next visit. And a lot of our care is, you know, it's done between the visits. Maybe 2/3 sometimes is done. And the visit is just sort of like an anchor of, okay, we're right, and I'm not being misled by what I'm hearing or seeing. But that's not where a lot of the care is happening in like advanced Parkinson's disease or things like that. Some disorders not, like dystonia and all, but in others, I think, yes. And so that model also then of training people and how you can guide somebody and then set them up for opportunities and also change their, I mean, that's, I think, the most important thing that we do. For all, everybody's obsessed with what they write and the trials and this, but I think it is very prescient, because if you train somebody well and then they go out or go all over the place, as is the people he trained all over the world, then each one's ripple impact is enormous. You know, and certainly for me, you know, when I see fellows who trained with me and then are now, you know, running places and then giving talks like at this meeting and others, that's the most meaningful thing, I think, that we do.
And training other fellows themselves.
Yes. And training other fellows.
Let's talk a little bit about the MDS and then come back to some things with your own career. How did you first get involved in the MDS?
Well, you know, I first heard about it probably through the academy, because in the 90s, many of the people who went to MDS, they were always at the American Academy, and David Marsden and Stan did that session afterwards, which was fantastic, and people were yelling at one another till 2 o'clock in the morning in the audiences, and it was just very exciting. And so then you know, I started to go to the meetings and started to submit things to the journal. And so met, you know, Tony Lang, who was the editor then, and then gave a course on movement disorder emergencies. And so started to and realize that, like, this meeting is really it for us.
Right.
And we're very, very fortunate, actually, because as I tell the fellows, and many of them do, everybody thinks their area is the best, and that's how it should be.
Right.
Ours really is the best, because the scope of what you could be interested in, even within movement disorders, and then the implications of that for other features of neurology, as well as art and culture and everything else, are very, very broad. And then for most patients who come in, we can help them.
Right.
Sometimes a lot. And that isn't true of some areas of neurology that are very, very interesting to people.
Right.
But, like behavioral neurology or memory, that many people go in there, they're fascinated by this, and then they misdirect because they just say, that's not for me, or,
Right.
or some other area that doesn't. But for us, it's, and so I started, and then I started with some committees and all, and I don't have experience with other specialties, but very clearly, senior people in the field were very open to sort of interacting and mentoring. I remember going to the ANA, they had the one-day satellite symposium in 1996. And when I was a resident and applying for fellowship, and, just seeing that, like, Dave Eidelberg was a great mentor to me at Cornell, and then I met Kapil Sethi there.
Right.
And, there were no airs about
Right.
the interaction, and they were just, they would just, bring people into the field.
Right.
And I think that's true of the MDS and also of many people who serve in the MDS.
Right. Well, I think there's a real shared enthusiasm for movement disorders.
Yeah.
A real passion that you might not see in some other fields. As you said, the field chooses us.
Yeah, I think so. I mean, it reflects sort of the challenges, I mean, you know this, I'm sure, better than I, that we do face challenges as clinicians in the U.S. in academics, and many of those are financial and time.
Right.
So if you want to do some things, you probably have to be willing to do them off hours.
Yes.
But honestly, for me, that's not work. That's sort of like, those are the cookies.
Right. And then I know this is your second year as chair of the Scientific Program Committee, which must be a huge responsibility and a lot of time. Tell us a little bit about how that's developed and
sure. Well, I first served on the CSPC in the planning for some of the Berlin committees, and certainly that committee is incredible because they're crafting the meeting, and the way they choose speakers and backup speakers. It was so interesting to watch, and then Francisco Cardoso asked if I would do this meeting as a chair for the Madrid meeting and for this meeting. And the other thing that you really see, and then I sort of say by analogy, is this meeting, which is like 4.5 days, is a little bit like a international music festival, but compressed. And you have thousands of people in the audience, and you have scores and scores of sessions or performances, and then interactive sessions and all this. There are so many moving parts.
Right.
It's unbelievable.
It is a symphony is a very good analogy.
And to get that all to work smoothly and then solve the problems as they go requires such tremendous expertise from the MDS and from the staff who run it. And you don't really see that unless you see it behind the scenes. And it's a little bit like how a music festival works with its administrative staff and all. You just go to the concert and it seems great, right? Everything worked. But there was a million decisions that had to be made so that it all looked like it was just natural.
Right.
And that's been very interesting to watch, as well as seeing the way master people sort of handle, and get everybody on the same page. Because of course people have their own pet interests and they would like more of this or that in the meeting, and more basic science or more cognitive or more this. And you have to sort of satisfy various people's desires of what they want to see, and also create something hopefully that people enjoy attending.
Right. I want to come back to music because I know that's been such an
Yeah.
important part of your life and your family life and your career. Tell us a little bit about that. Maybe I know your family is all very musical, and you were a violinist.
Yes. I mean, I started on piano at 5. I have perfect pitch. Probably my parents recognized it, and then I was a pianist till 10, and then started late on violin, but had a lot more natural ability on the violin because I was able to get into pre-college at Juilliard by 14, and continued to study. And then I was very fortunate to be able to go to Tanglewood as a fellow for 3 years before medical school, and then 2 summers. And I met my wife through actually a music camp that we had both attended and then were counselors on, and we've been very privileged to have 3 daughters, and they all went through Juilliard pre-college as well, 2 violin and 1 cello. And I, went to almost all of the lessons, first just as the observer, and then as an accompanist. It was a lot cheaper than paying for accompanist. That itself was not only very meaningful, of course, but also interesting because you see, it's a guild, just like ours is a guild. And, how does a great teacher get a student who's 6 or 8 or 10 or 12 to improve and do that in a positive, supportive way? And when are they pushed, and when? And so that was just fascinating to watch. And they all still play. My oldest I decided to do it professionally, and it's not easy.
Yeah.
She's done very well. She's in a professional quartet and living in New York City, as the other 2 are. The other 2 decided not to do it professionally. And I do, still practice, and I don't perform as much, but do occasionally perform. And yeah, that many people have this sort of vested interest in music, and it's the same thing. You're not doing it for a purpose. You're doing it because you have to.
Right.
And certainly, the opportunities that were given to me to work with some of the most extraordinary senior musicians at Tanglewood and in other places for free were, life-changing experiences. And so I view it sort of as a privilege to be able to take care of musicians who run into difficulty.
Right.
And, then also to meet them,
Yeah.
which is quite an extraordinary population
Right.
of patients.
And that's been a big part of your career, something you made a lot of contributions to, movement
musicians
disorders in musicians. Tell us a little bit about that and the challenges that you find there, and the joys that you get from there in helping patients.
Yeah, I mean, the first, Glenn Estrin, who's one of my closest friends, was, I think, the 3rd musician I saw at Columbia with dystonia, and he developed embouchure dystonia. And he had played all over the world with Frank Sinatra and in orchestras and theater and this, and it took him 7 years to get diagnosed.
Right.
And so he said, this is ridiculous. And so he wrote he wrote a little story in the Musicians Union paper, and we explained his course, and then that led to scores of patients just coming in, and we started the foundation. And over the years, I've probably seen about 300 or 350 musicians with professionally related other embouchure or hand dystonia. And the amazing thing is the perseverance and resilience of these patients.
Right.
For the hand, also the advances in the application of botulinum toxin, particularly using high-resolution ultrasound and e-stim, something I don't do. I do
Right.
Botox above the neck, but my colleagues did. Dave Simpson at Mount Sinai and now Pat Drummond at NYU has been transformative. What we would sort of nihilistically always say, you're never going to get them better, it's never going to be
Right.
enough, they're not going to be satisfied and all. Turned out that was not true.
Right.
And it required a little bit of ingenuity, how to use it, how to select, what to look at, what was a primary movement versus compensatory. You have to have familiarity with the instruments. You have to have the instrument in the office.
Right.
So we have a keyboard. Everybody else brings theirs, but you can't bring your piano.
Right.
And then you see amazing things. You see all of a sudden, toxin lasting 6, 8, 10 months.
Right.
And why did that happen? Or it went away. Where did it go? We don't say dystonia usually
Right.
goes away. So all these things then and of course for some lucky ones, they returned to doing what they were doing at a very, very high level, and that's very rewarding, of course.
Right. Because most of these, as you know, are professional or semi-professional musicians, so their career is on the line.
Oh, absolutely.
For these, yeah.
It's what I tell fellows and all, when you have to give a musician a diagnosis of dystonia,
Yeah.
the emotional impact for them is often similar to if you're then telling somebody with Huntington's disease they have
Right.
Huntington's disease. And you say,
Right.
how can that be? Because musicians live to play.
Right.
They don't play to live. And everything that they have developed and experienced has been surrounded on the fact that they are a musician. Mm-hmm. Everyone they know, that the sense of self-worth, what they do every day, future goals, etc.
Right.
And you suddenly say you can't do that anymore.
Right.
It's devastating.
Yeah.
And I would say for most there was nothing, and now for that, we have not made the same gains in embouchure. I think the problem is just very, very challenging.
Right.
But now a patient comes in and they have unilateral dystonia of one finger as a pianist and all, compared to 30 years ago. Now I say, oh, we know what to do.
Right.
We can almost certainly get that better, and maybe a lot better, and maybe even better enough,
Right.
which couldn't say when I started.
Yeah. Thinking back, you've made contributions in a lot of areas. Is there something that you would really highlight as something you're most proud of, or your most significant contribution? And again, you've made many, so it's hard to choose.
Well,
one.
I have been fortunate. I think one of the things that I found most interesting was when I started looking at patients who had severe post-hypoxic myoclonus.
Right.
And then going out on a limb and doing what Stan did, which was when he wrote review articles in the 80s and 90s, he pulled the entire world literature. Mm-hmm. And then if you go back in the literature, you find that there's few single case reports of alcohol responsivity,
Right.
sometimes exquisite. And that led to looking at alcohol response movement disorders and then to using sodium oxybate in this
Right.
manner. And that I think has been very intriguing, because it also led to a collaboration with Christina Simonian at Mount Sinai and federally funded work looking at mechanistically using fMRI what is going on in dysphonia patients before
Right.
and after treatment, or vocal tremor patients. And it's a little bit like the inverse of levodopa, when you would have a patient come in back then and you'd give them, and they would stand up.
Right, right.
This is a patient who can't speak, let's
Right.
say, and then if they're really responsive and they're a responder, then they suddenly can, and it lasts for a period of time. It's kind of extraordinary when it happens.
Yeah.
And that was a little bit just sort of like a leap of faith that maybe this will work if you think biologically that these are similar. Mm-hmm. And we're hoping that will translate into therapy for some treatment refractory, spasmodic dysphonia patients, like
Right.
abductor dysphonia patients
Right.
that are very difficult to help.
Right.
And, that is very meaningful to use something that, when used carefully, can be used in the select group of patients and for which we don't really have another
Right.
option.
Right.
It's quite, I think, meaningful for me.
What about work-life balance? That's something we all struggle with.
Yes.
And I don't know if you have any real good answers, or if anyone ever achieves it. But
I can only
what's
tell
your-
you what I did, and what I did was, when my kids were young, I cut every corner I could.
Yeah.
I was leaving the office at 5, mostly to get to lessons, and practicing in the morning and then afternoon, night. And so time until when they were little, kids were asleep, was not my time. And so it would begin after they went to bed.
Yeah.
I probably am not the poster child, if you will, for achieving a good work-life balance. And I think that reflects sort of a obsessional nature to personality, which is I go all in.
Right.
If I'm interested in it, to me, being able to, read and write things, I could do that on a Saturday and Sunday and not be disturbed by that.
Right.
But that's not normal. I understand it's not normal. It's okay. But, but I think it's now increasingly important to understand this balance. And I think also just to, like just having, set even paternity leave. This is something that didn't exist at all. One of our kids was born on a Saturday morning. Well, I was back as a resident Monday.
Yeah.
That's just, nobody would consider how could you consider anything else?
Right.
Similarly, fortunately, that has changed.
It has, in a good way.
In a good way.
Yeah.
But, and I think it's also very important psychologically because, particularly the last 4 years or so have not been easy.
Right.
And one of the concerns I have is seeing people who were fellows in training and all choose not to keep doing it. They decide to do other things, which is fine. People have to do whatever they need to do, but then our field, at least in the US, is underpopulated. There's always ads.
Right.
And only 40, 45 people decide to train in it each year.
And we're all very backed up.
And the demand is extraordinary, and it's just gotten worse with COVID. So, achieving that, I think, is critically important.
You mentioned writing, and one thing that I learned about you, we both like pens.
Yes.
But I remember you told me that you, when you do your drafts of papers, that you do them by hand.
I can't write on a computer. And I guess, this goes back to childhood, because my dad used fountain pens, and his obsession was with Einstein. And so we had posters of Einstein growing up in the house. And I think part of his obsession was what he accomplished as a patent clerk. That had nothing to do with it. He was just doing his stuff. And so he had notebooks in which he just wrote and did problems in this. And so I did that too. But I don't know what it is, but I think there is a difference when you formulate text by writing it than when you're typing it.
Right.
And it probably has to do with the organization and control of the hand and also speech. So I write them out and then laboriously then type them in, edit a little bit. But what's interesting is if you can then look back some years later at what you wrote. And someone who I would consider a mentor and was a friend, even partially, was Oliver Sacks. And of course, that's what he did. He was never without a notebook, and he was never not writing in it. And I think throughout his life, he filled 1,000 notebooks, always with fountain pen.
Yeah.
And I think later he discovered that when he was writing certain things, all he really had to do was go back to the notebook from that time, and it was sort of already written.
Right, right.
Which is an interesting phenomenon.
Right. You're probably unique in terms of,
writing
the first draft out on paper. I
know.
think most people are using their computer.
Yeah.
But it's a nice habit, and you obviously enjoy it. You like, as I do,
Yeah.
using nice pens.
Yeah.
To change topics just a little bit now, in terms of your career, you were at the Neurological Institute,
Right.
and then from there, you stayed on there from the faculty for a little while.
Yeah, I was a fellow from 97 to 99, and I was on faculty till 2010.
And then you moved to Mount Sinai.
Mount Sinai till 2017, and then to NYU.
I see.
And, that, as I joked, that reflected either, I joked that my goal is to work at every hospital on the island of Manhattan.
Right.
And since when you were training at Cornell, you were also working at Sloan and at HSS.
Right.
When I was at Columbia, I would attend at Harlem, so I'm getting there.
Right. I think you've got a lot more hospitals to go.
But all kidding aside, when I was at NI, it was a golden period. Bud Rowland had built arguably one of the greatest clinical neurology departments.
Mm-hmm.
Each division could have been put as a department somewhere.
Yeah.
And there was a focus and a way of approaching neurology that came from him, his personality and his drive, etc. And certainly the division there was amazing, with Stan and Paul Green and Blair Ford, and then Bill Dower and Elon Lewis and Tim
Right.
Lynch and
Susan
Bob
Bressman,
and
yes.
Susan Bressman, and then she
Right.
went downtown, and Bob
Right.
Burke, and it was going great. And what changed were finances. What changed were finances of the university, not even the medical center, and that led to a new dean coming in and all these policies that, it's not a secret, many departments there were very challenged, and neurology was the last one, and probably movement was the last bastion,
Yeah.
because Stan was still able to protect it, but the writing was on the wall. So I felt very lucky to be able to go to Sinai and met many wonderful colleagues there, and Paul actually joined there and was there for a while, and things were going great there as well. And then there were changes sort of in who was in charge and this and that. And then this opportunity came up to join NYU, and I was fortunate to go there. And Andy Fagan came, and now we have a lot of junior faculty and others. And it's no secret that their hospital has been able to do amazing things. They
Right.
now have a free medical school with
Yes.
$650 million endowment, and transformed delivery of clinical care, and in most specialties, and they've been the #1 ranked department in neurology and neurosurgery the last 2 years, and the department is enormous.
Yeah.
Enormous, probably 230 neurologists, of whom 100 are like primary faculty. So that has been very rewarding, as well as being able to see junior faculty like Giulietta Ribaldi and sort of make the leap to independence and in research, and then Un Kang joined us, and so that, and we've been able to train both American fellows and Italian fellows who run and then go back to Italy, and also that has been very rewarding.
What about through your career? Are there any particular challenges that you faced, or maybe some disappointments, and how did you deal with those? We all have
we
those.
all do. I think, big challenges are often seeing that things are changing in your institution and not for the better. And I think I learned an important lesson as a resident, which is not anything anybody talks about, but if you're at a place for a while and things are not going well, and you just realize your opportunities here they look much better in the rearview mirror than they do today, it's a big leap to jump.
Right.
But it's been the best thing I ever did to go. I would not have met collaborators. I would not have seen other styles of neurology, of leadership, whatever that is,
Right.
of how to get people to work towards a common goal. But, you know, one of the biggest challenges, to be very honest, was financial.
Yeah.
And, you know, trying to make it early on, living in the city with 3 kids with an academic salary was a big challenge.
Yeah.
And I think that's being better addressed today. But
Right.
there was sort of an idea that, oh, you went into academics, but you're not in it for the money and this and that, but you still got to eat, you know?
Right, right.
You still want to at least provide basic things.
You've got
and
a lot of music lessons to
yeah,
pay for.
well, that too. And, you know, so I think now there is recognition that, like, you want to not see people burn out and then go to farmer. Not that there's anything wrong with that, but to sort of abandon this. You have to at least support them so that they can support themselves.
Yeah. The last thing that I want to talk about is, because a lot of junior people hopefully be viewing this and view you as a role model, what advice would you give to early career or even trainees at this point in terms
Sure.
of the long view for their career?
Well, the first thing is that, as I tell the residents who are applying for fellowship, and you see them, we've done it virtually now, is that if they've decided to go into movement disorders as fellowship and afterwards they're already 90% done. They made the right choice.
Right.
Okay? And that's because no matter what, if they're willing to work, they can probably choose where they want to work.
Right.
And not only that, in what sub-area they want to do it. And that's not true for certain subspecialties like stroke, ICU, and all these other things. In terms of what to do, I think it's very important for people to be honest with themselves about what their strengths and weaknesses are. I certainly came to that realization early on, and, you know, I was interested in phenomenology, and it was sort of, well, what do you know, but I sort of persevered with it, and I think if you do that, you're going to be passionate about it.
Right.
The other is to realize that your job and your career are separate. And often the people who could help you or mentor you may not be in your individual institution. They're probably in the society, and they're probably out there in the committees, etc., and they're willing to help. And they can actually have a big impact on helping you if you, depending on what you want to do. Because the local environment, as you know, it can sometimes be competitive, or there are all these emotions that are going on. And meeting people outside of your city or local area is very important.
Right.
I have found.
Right.
Yeah.
Friendships and collaborations, these
Absolutely,
are all very
and
important.
You know, it also gives you a perspective, because we're in some ways privileged practicing in the U.S., and there's so many areas of the world where what we take for granted is not available. And it's sort of the same even in the U.S. in terms of the insurance fiasco and who can't get care, but getting outside of your little box, I think, is very important.
Right. Well, you did mention being passionate, and you certainly have had that. I think that's the thing that drives most people who are successful forward, is really being interested in the field, finding it fascinating, wanting to make a contribution, and particularly being a mentor to others. And you've certainly been all of those things, Steve.
Well, thanks. Yeah.
Good. Well, listen, thank you again for the interview.
Well, thank you for you know, I must admit, you know, when you asked would I do this, I always have this sort of imposter syndrome going through my head, like, wait a minute, you know, are you sure? Are you really?
Yes.
Okay. Okay.
Right.
So, but I appreciate it very much.
Good. Well, I think part of the imposter syndrome is a show that you have some humility. So we think about always in a negative way, but I think there is a positive reflection of having a little bit of an imposter syndrome, that you have humility. So again, thank you very much, and thank you to the MDS for putting this on.
Yes, thank you. Appreciate it very much.